Today today our topic of discussion is venous thromboembolism and thrombotic disorder in ICU. It's actually a vast chapter and multiple topics are there, but I have taken just relevant to ICU and most commonly disorder that we interact in ICU. First is deep venous thrombosis. The DVT and pulmonary embolism are most common but often underdiagnosed finding in ICU. Up to 43% patient without prophylaxis in medical ICU develop DVT. In old trial has shown that at least 63% DVT cases are detected post-mortem where there was neither suspected or diagnosed DVT. Now this is Virchow triad of thrombosis, that is the how the thrombosis developed inside the body. So hypercoagulability of blood, vessels wall injury and status of the blood. These three is making a triad, and any of this, any problem of this, any three of this, any one of these three can lead to venous thrombosis. So in hypercoagulability of blood, that can caused by cancer, thrombophilia or inflammatory disease. Vessel wall injury, surgery, direct trauma, chemical irritation or inflammation, and status of blood like immobility, varicose vein, venous obstruction, etc. Now cause. Inherited thrombophilia due to factor V Leiden mutation, prothrombin G20210A mutation, protein C deficiency, protein S deficiency and antithrombin deficiency. Among all these three, factor V is common. Acquired, much more common. Presence of central venous catheter, surgery, trauma, immobilization due to surgery, trauma, particularly orthopedic surgery, drugs like OCP, hormone replacement therapy, tamoxifen, asparaginase, comorbidity like heart failure, nephrotic syndrome, inflammatory bowel disease, myeloproliferative disease, solid organ malignancy, all these things can lead to venous thrombosis. Now this is Wells criteria for DVT. It has few parameters and some points. When points is -2 to 0 total point, that is for low risk for DVT, 1 to 2 is moderate risk for DVT, and more than 3 is high risk for DVT. Clinical features: swelling of limbs, extremity discomfort, dyspnea, erythema of limb and limb discoloration usually find in venous thromboembolism. Now few nomenclatures. There is called provoked DVT, that is DVT that is precipitated by an event like surgery, trauma or drugs, etc. Unprovoked DVT, DVT without identifiable risk factor. Proximal DVT, mainly DVT located in the popliteal and femoral or iliac vein. Long-term anticoagulation means used for definite period, usually 3 to 6 months, maximum 12 months. And extended anticoagulation, that is beyond the definite period, sometimes indefinitely. Suspected lower extremity DVT, if we suspect a patient with lower extremity DVT by Wells score or clinical picture, then we have to go for a venous duplex scan. If it is positive, we need to evaluate coagulation profile, thrombophilia, malignancy and treat accordingly the cause. If the scan become positive but clinically probability of DVT is scan become negative, but clinically probability of DVT is very high, then we need to repeat the scan. Otherwise we need to just observe the patient. Therapy for venous thromboembolism. So in a non-critical care setting, VTE usually routinely treated either with at least 5 days of unfractionated heparin or low molecular heparin or fondaparinux followed by warfarin or a direct oral anticoagulant use. In ICU, usually we prefer unfractionated heparin because of short half-life and complete reversibility by protamine sulfate. IVC filter placement is indicated only in two situations: acute DVT and a contraindication to anticoagulation like recent intracranial hemorrhage or stroke or any cerebral malignancy or any bleeding dystasis, all these things, and recurrent pulmonary embolism despite of therapeutic anticoagulation. So this is about anticoagulation. So there is two types, one is oral, one is parenteral used. So in case of parenteral, there is antithrombin, that is bivaluridine and argabatran and hirudin. In case of parenteral, factor 10A inhibitor, fondaparinux, that is one of the commonly used. Both, I mean, factor 10A inhibition and antithrombin inhibition done by heparin. In case oral, there is a 3 types, mainly antithrombin, that is dabigatran, direct 10A inhibitor, factor 10A inhibitor, that is rivaroxaban, apixaban, edoxaban, and others like vitamin K antagonist, warfarin and acetrom. So this is a difference between novel anticoagulants or NOVAC, that is dabigatran, fondaparinux, rivaroxaban, apixaban and edoxaban. So here we can see that more or less creatinine clearance is the one of the important factor whether we should, I mean, CKD disease we have to, or dose optimization or contraindication is there. In case of rivaroxaban, apixaban along with CKD, CLD also a contraindication for use. Mainly indication for VTE or PT treatment and prophylaxis, stroke prophylaxis in non-valvular AF and DVT prophylaxis in TKR, total knee replacement or hip replacement surgery. Now heparin induced thrombocytopenia. Heparin induced thrombocytopenia is characterized by fall of platelet count and hypercoagulable state that occur in patient exposed to any form or any amount of heparin product. HIT can occur in up to 5% of patients exposed to heparin product. Heparin induced thrombocytopenia causes hypercoagulable state where up to 50% develop thromboembolic complication and associated with mortality up to 30%. So classification, it has classified into 2 types, type A and type 1 and type 2. Type 1 is non-immunomediated reaction, that is more common, can occur as early as day 1. It is mild reaction and platelet counts will spontaneously normalize even if heparin continued. And type 2 is antibody mediated reaction, occur after 5 to 14 days of heparin exposure. Serious reaction leads to life-threatening complication. So pathogenesis of mainly type 2 of HIT. Heparin binds on the platelet factor 4 and from heparin PF4 complex, and this trigger production of IgG, IgA or IgM antibody. Now this IgG antibody attached to heparin PF4 complex on platelet surface and platelet activation takes place. These activated platelets then release prothrombotic substance which creates the hypercoagulated state and thrombosis. So clinical pictures: sudden onset pain, redness, swelling of arm and legs, ecchymosis, skin necrosis, erythema, venous thrombosis are more commonly seen than arterial thrombosis. Now 4 T-score for probability of HIT. So there is a 4 parameters like thrombocytopenia, timing of decrease in platelet count, thrombosis or its other sequence like proven thrombosis, skin necrosis, all these things, and other causes of thrombocytopenia whether it is evident or not evident. So if it is 0 to 3 points, it is the low probability of HIT, 4 to 5 points intermediate probability, and 6 to 8 points is high probability. So risk of HIT around 50% when it is high probability. So clinical diagnosis of 4 T-score should be confirmed with PF4 ELISA and serotonin release assay. PF4 ELISA is highly sensitive but low specificity. So a positive ASRA confirms HIT. So even if PF4 ELISA is negative but SRA serotonin release assay is positive, then also it confirms HIT. So treatment: stop all heparin. This is for type 2 heparin induced thrombocytopenia. Need to stop all heparin, even low molecular weight heparin. Use direct thrombin inhibitors, and plasmapheresis can be an option. Now pulmonary embolism. From DVT next come with pulmonary embolism, which is another common phenomena and we encounter more commonly in ICU. So in pulmonary embolism there is a increased pulmonary vascular resistance because of release of serotonin and thromboxane A2 and hypoxia. And this causes actually increased pulmonary vascular resistance, leads to increased right ventricular afterload, which causes RV dilatation and dysfunction. and as there is a ventricular interdependence, there is a reduced stroke volume, hypotension and decreased coronary blood flow. So pulmonary embolism presents with vague symptoms such as pleuritic chest pain, hemoptysis, acute circulatory collapse and acute onset dyspnea. But contrary to common belief, dyspnea may be present only on exertion and absent during rest. Patient may also present with orthopnea, while some patient present with features of DVT only. So clinical picture of pulmonary embolism is not specific. This is modified Wells score for pulmonary embolism detection, or like clinical sign and symptom of DVT, no alternative diagnosis, heart rate more than 100, immobility more than 3 days or surgery in previous 4 weeks, previous DVT or pulmonary embolism, hemoptysis, malignancy with active treatment in the past 6 months or under palliative care. When the score is more than 4, the chance of pulmonary embolism is more. Apart from Wells score, modified Wells score, there is simplified pulmonary embolism severity index. It has few parameters like age more than 80 years, active cancer that is less than 12 months or undergoing treatment, chronic cardiopulmonary disorder, pulse more than 110, systolic blood pressure less than 100 and arterial oxygen saturation less than 90%. It has divided into 2 classes, low and high risk. Low risk only if the score is 0 and high risk when score is more than or equal to 1. Now this is pulmonary embolism rule out criteria. So it has also few variable. This is done for low risk patient. If a low risk patient, we usually done pulmonary embolism rule out criteria. If all this negative, then we can say the patient is not having pulmonary embolism. If pulmonary rule out criteria is positive, then we have to go for D-dimer test and to decide further test or treatment according to D-dimer report. But if it is high risk patient, then pulmonary embolism rule out criteria is not indicated. So approach to suspected case of pulmonary embolism. So if patient having acute onset breathlessness, the probability of pulmonary embolism based on clinical and prediction rules. If it is low risk, then we have to go for pulmonary embolism rule out criteria, and if negative, then we rule out, as I told earlier. If it is positive, we have to do D-dimer. If D-dimer is negative, then we can rule out the pulmonary embolism. If D-dimer is positive, then we have to go for CTPA, if it is available. In high risk patient, we have to take the patient for CTPA if there is no contraindication or availability. If CTPA is negative, we can rule out pulmonary embolism. If CTPA is if CTPA is negative, we can rule out pulmonary. If positive, then we can directly say patient having pulmonary embolism. If CTPA is not available, then we have to do compression ultrasound scan or 2D echo, and depending upon their report, we have to treatment accordingly. And if compression ultrasound and echo is negative, but patient still having high risk for pulmonary embolism and clinical picture suggestive of pulmonary embolism, then we have to do for some other tests.
So just go back one slide. If CTPA is not available, then you see compression ultrasound is very easy to do.
Yes, sir. Bedside, yes, sir.
Compressed it tells you whether there is a clot or not. Same with an echo situation. So if you see a clot on compression ultrasound, the treatment is essentially the same. CTPA, if you find that, then it becomes a high probability and it will not influence your treatment. So because we are talking about P. If you are talking about VTE, I think your COS and echo would be very easy to do it. Routine blood and routine investigation of the body.
Another approach to acute pulmonary embolism according to patient condition. If it is hemodynamic stable, then we can go for CT scan, and if it is negative for pulmonary embolism, we have to look for alternatives. If it is positive, then we have to treatment. If hemodynamic not stable, then bedside echo or transesophageal echo we have to do, and if there is a right ventricular dysfunction present or not. If it is present, and we have to confirm pulmonary embolism with additional test. If it is not present, then look for alternative diagnosis. So additional test like VQ scan, it is portable but not available in every center. ECG, sinus tachycardia with right axis deviation, S1 QT33, right bundle blind block, all these can be seen in ECG. But mainly done ECG to rule out a acute myocardial infarction. It has low sensitivity and specificity for pulmonary embolism diagnosis. Chest X-ray, there is a few signs are there like focal oligomenia, dilated descending pulmonary artery, enlarged pulmonary artery, all these things can seen. But it too has low sensitivity and specificity. Chest X-ray usually done to rule out other pulmonary complication.
VQ scan is not quite portable actually. You got to go to a nuclear medicine department and gamma camera outside. So it's not just ICU machine anymore. Now you get portable CTs also. I know this hospital in Pune, neurosurgery unit or into VQ scan is not a portable.
Now MR angio and thrombosis in pulmonary artery can be seen, but low sensitivity. D-dimer. D-dimer if negative rule out PE, but in low risk patient. In high risk patient, D-dimer value does not matter much actually, and there is a age adjusted D-dimer value after 50 years of age. BNP and troponin may be high due to RV strain, complication of pulmonary embolism actually suspect this. Compression ultrasound of proximal lower limb vein, 4-point compression, bilateral femoral and popliteal. If negative, pulmonary embolism is unlikely. Now 2D echo finding in pulmonary embolism. One is RV dilatation, right ventricular hypokinesia or dysfunction, paradoxical septal motion, D-shaped left ventricle, and tricuspid annular plane systolic excursion is less than 16, associated with high risk for 30 days mortality. Now treatment. Treatment is pulmonary embolism specific treatment, that is if patient having shock or hypotension, we have to thrombolize the patient. Thrombolize have three types. One is systemic thrombolysis, one is catheter directed thrombolysis, and another is surgical embolectomy. If suspected pulmonary embolism score index more than 1, right ventricular dysfunction on imaging, and elevated troponin and BNP, if find all present, then we have to do anticoagulation along with rescue thrombolysis. If anyone is positive, then we have to go for only anticoagulation. If simplified pulmonary embolism severity index is 0, then we can treatment at home and follow up accordingly. So treatment, all patients should have, this is the gross general treatment as per ICU protocol with acute pulmonary embolism. All patients should have continuous ECG and blood pressure and oxygen saturation monitoring. Peripheral intravenous access has to be secured, and intravenous fluid may be started gradually. Studies have shown that although small volumes of intravascular fluid increase the cardiac index, aggressive fluid resuscitation result RV dilatation and RV dysfunction. After a cautious attempt of fluid bolus, vasopressor should be started without attempting to give further fluid. Now, vasopressor of choice, there is no as such specific for pulmonary embolism, nor adrenaline usually used. Empiric anticoagulation need to be started for all patients with suspected or proven pulmonary embolism based on their hemodynamic stability, anticipated need for thrombolysis, and presence of renal dysfunction or other comorbidity. Unfractionated heparin is started at the dose of 80 unit per kg, followed by infusion 18 unit per kg per hour, and further titrate according to activated partial thromboplastin time. After initial therapeutic anticoagulation, further anticoagulation is continued with vitamin K antagonist or non-vitamin K antagonist oral anticoagulants. Now thrombolytic agents, this is streptokinase, urokinase, altiplase, retiplase and tenecteplase. But among them FTI approved is only 3, streptokinase, urokinase and altiplase. But streptokinase and urokinase is first generation and has multiple complications. Now, catheter directed therapy in pulmonary embolism. There is techniques like catheter directed thrombolysis, ultrasound assisted thrombolysis, suction thrombolectomy, rheolytic thrombolectomy, rotational thrombectomy, and aspiration. All this under trial, under study, details study mainly done with catheter directed thrombolysis and USG guided assisted thrombolysis. Both have advantage and disadvantages. Now, rescue strategy: surgical embolectomy is performed in hemodynamic unstable patient where the thrombolysis has failed or is contraindicated. It is high mortality, particularly in elderly, and it better reserved for centers with great experience and experienced surgeon. Another is vena cava filter that I have already told earlier is recommended only if there is a contraindication to anticoagulant treatment in patient with acute pulmonary embolism or proximal DVT. The results from available trials do not support the use of vena cava filter in patient with PE with anticoagulant treatment can still be done. Now, ECMO. In setting up, this is also a rescue therapy in setting up massive pulmonary embolism and hemodynamic failure. ECMO helps in optimizing of right ventricular fluid load, reducing hypoxia-induced rise pulmonary vasoconstriction, and helps in maintaining systemic blood pressure and right ventricle coronary perforation by optimizing afterload, resulting overall improvement of biventricular function. Now, after that we come to thrombotic microangiopathy, another thrombotic disorder in ICU. It is the lesion of arterioles or capillaries where the complete or partial occlusion of the vessel lumina occurs due to thrombosis. The main features of TMA are consumptive thrombocytopenia, microangiopathic hemolytic anemia, and microvascular thrombosis induced organ injury. So, what are the causes? Main common causes are hemolytic uremic syndrome, transient thrombocytopenic purpura, infection like systemic infection, HIV, H1N1, etc., autoimmune disease like SLE, antiphospholipid antibody syndrome, systemic sclerosis, drugs like clopidogrel, OCP, sirolimus, etc., pregnancy, HELP syndrome, malignancy mainly stomach, breast and prostate cancer, and glomerulonephropathy. Now, classical or typical HUS, it is the mainly find in pediatric population, caused by Shiga toxin producing thrombosis, hematological microthrombotic pathway activation which ultimately leads to platelet aggregation and thrombus formation. Clinical picture, as I told, pediatric population, child less than 5 years of age. Watery diarrhea may progress to bloody diarrhea with hemorrhagic colitis, fever, vomiting, pain, abdomen. Second phase occurs 3 to 4 days of onset of GI symptom, AKI, anemia, severe CNS changes, hyperkalemia, high urea, creatinine, hematuria, altered mental station may be seen. Atypical HUS actually affect in adult, and it is rare than classical HUS, mostly sporadic. It has two types, primary and secondary. Primary is because of hyperactivity of alternative complement pathway result activity of membrane attack complex, and secondary due to direct endothelial damage by drugs, autoimmune disease or malignancy. Prognosis is poor. Laboratory finding like microangiopathic hemolytic anemia leads to anemia, low haptoglobulin, and thrombocytopenia, high LDH and altered RFT. Normal LFT and liver function test and coagulation profile seen in HUS. Peripheral blood smear shows cystocytosis, reticulocytosis, helmet cell, blood cell, and absence or giant platelets. Low GFR, hematuria or proteinuria seen in urine. ADA MTS activity is more than 5 to 10%. I come to later. And low complement level in primary atypical HUS. Treatment: typical HUS is aggressive hydration. Early antibiotic is indicated in sigilosis but avoided in E. coli. Do not use anti-motility agent. Shiga toxin binders are not effective. Plasma exchange with FFP transfusion is effective along with dialysis. Atypical HUS, urgent empirical plasma exchange is important because atypical HUS has high mortality and 50% patient developed end-stage renal disease. Eculizumab is approved for atypical HUS, but it increased chance of meningeal disease. Dose around 600 mg per kg for 4 weeks. Renal transplant only for STEHUS, that is Zika-like toxin producing E. coli. Now come to transient thrombocytopenic purpura, that is almost features are similar with HUS with some difference. TTP is a medical emergency that occurs due to deficiency of ADA MTS 13. So it is a metalloprotease that cleaves the von Willebrand fracture. So it rarely causes thrombotic microangiopathy, but without treatment mortality is as high as 90%. So rapid diagnosis and treatment is critical. It has two types, congenital and acquired. Congenital mainly autosomal recessive, deficiency of ADA MTS 13 seen in pediatric population, but congenital causes are rare. Acquired is more common. Here autoantibody against ADA MTS 13 seen affected in adults and occurs secondary to massive endothelial activation with release of ultra large von Willebrand fracture that cannot cleared by ADA MTS 13. This ultimately leads to platelet aggregation and thrombosis. Risk factor more or less same as other thrombotic risk factor: pregnancy, infection, drugs, connective tissue disorder, other surgery. Clinical features: there is a pentad for TPT, MAHM, microangiopathic hemolytic anemia, thrombocytopenia that is more severe than HUS, renal abnormality, this is less than HUS, neurological abnormality like coma, confusion, headache and seizure, this is more common than HUS, and focal neurological abnormality is actually rule out the TTP. It is always generalized neurological abnormality seen, and fever. These are the pentad for TTP, but other than this, jaundice, pallor, fatiguity, chest pain, heart failure, abdominal pain, etc. can seen. Now plasmic score. Plasmic score is important as TTP is high mortality and early treatment is necessary. Plasmic score decide whether patient is high risk, intermediate risk or low risk for development of TTP. So there is 7 parameters and each have 1 point. Patient is high risk if point is 7, total point is 7, intermediate risk 5 to 6 and low risk 0 to 4 points. Treatment: do not wait for ADA MTS 13 report if suspicion is high. Daily plasma exchange 1.5 liter plasma volume of FFP exchange daily, FFP 30 ml per kg until plasma exchange start, prednisolone 1 to 2 mg per kg per day, and avoid platelet transfusion, splenectomy if everything fails. Novel therapy for TTP, this is actually under trial and not recognized till now, but this is tried for treatment for TTP. Rituximab, N-acetylcysteine, bortezomib and recombinant ADA MTS 13. Now another important and emergency situation is antiphospholipid antibody syndrome. It is an autoimmune disorder which manifests clinically as recurrent arterial or venous thrombosis and or fetal loss. Autoantibody against membrane anionic phospholipid, that is anti-cardiolipin antibody, anti-phosphatidylserine antibody, or their associated plasma protein beta 2 glycoprotein 1. Classification: it is mainly classified into 3 types: primary aplasia not associated with other autoimmune disease, and secondary aplasia associated with other autoimmune disease like SLE. Catastrophic aplasia, that is much more severe and that is for critical care point of view and emergency point of view, that is rapid organ failure due to generalized thrombosis, rare but high risk of mortality. So triggering factor: infection, syphilis, hepatitis C, HIV, malaria, sepsis, drugs like procainamide, hydralazine, propranolol, phenytoin, genetic HLA associated DR4 or DR7, other risk factor for thrombosis as earlier, OCP, trauma, immobility, nephrotic syndrome, high LDL, malignancy, etc. Pathophysiology: actually pathophysiology remain unclear, but proposed mechanism are beta 2 GP1 mediated complement activation, that is the most proposed mechanism for APLA, Apart from that, antibody production against protein C, protein S or prothrombin, enhance endothelial adherence of platelets, activation of vascular endothelium for platelets and monocyte binding, and immunoreaction against oxidized LDL. This any could lead to APLA syndrome. Clinical consequence: multiple or every organ can be affected by APLA. Neurologically, stroke, transient ischemic attack, cognitive dysfunction, cardiologically myocardial infarction, ischemia or valvular heart disease, hemolytic anemia and thrombocytopenia, purpura, livedo reticularis, ocular thrombosis, optic neuritis, pulmonary embolism, pulmonary artery hypertension, renal artery thrombosis, spontaneous abortion, all this can be seen. Mainly APLA is concerned in gynecology because of as patient is present with recurrent fetal loss. So diagnosis for definite APLA is there is a clinical criteria and laboratory criteria. For definite diagnosis, present if at least one of the clinical criteria and one laboratory criteria is made. Among clinical criteria, it is one is vascular thrombosis more than one, that could be arterial, venous or small vessel thrombosis. Second is pregnancy morbidity more than one fetal death at or beyond the 10th week of gestation, more than one premature death before 34 week of gestation because of eclampsia, severe preeclampsia, placental insufficiency, and more than 3 consecutive embryonic loss before 10 week of gestation. In laboratory criteria comes to lupus, anticoagulant positivity more than 2 occasions at least 12 week apart, anti-cardiolipin antibody in medium or high titer on 2 or more occasions at least 4 weeks apart, and anti-beta 2 glycoprotein 1 antibody in medium or high titer on 2 or more occasions at least 12 weeks apart. Now other tests we have to do CBC, PT, APTT. For APLA there is kaolin clotting time, dilute Russell Viper venom test, and tissue thromboplastin inhibition test. Treatment: asymptomatic in whom blood test is positive but patient is asymptomatic, no treatment is required. Secondary thrombosis prevention is lifelong warfarin in for secondary cases. Acute thrombosis, if they present with acute thrombosis, then low molecular weight heparin followed by warfarin or direct oral anticoagulants. Rituximab, eculizumab, ACQS, prednisolone, IVIG, statins are tried in difficult to treat cases. And last option is autologous hematopoietic stem cell transplant. Now target INR. If it is arterial thrombosis, target INR is 3. In case of venous thrombosis, target INR is 2 to 3. But in case of recurrent thrombosis, 3 to 4 along with low dose of aspirin. Now catastrophic APLA. It is rare but life-threatening form. Acute onset small vessels occlusion confirmed by histopathology. 3 or more different organ involvement simultaneously or within a week. All 3 organs will be involved, and anti-cardiolipin antibody is more and lupus anticoagulant also high. So these 4 are the main criteria for catastrophic APLA. Triggering factor will be there like infection, surgery, malignancy, drugs. Laboratory finding as like microangiopathic hemolytic anemia, thrombocytopenia, ferritin more than 1000 nanogram per ml, and antibody positive as I told earlier. Kidney is the most common organ that affected, followed by lung, CNS and cardiac. Treatment: definite catastrophic APLA if life threatening is treated with heparin, pulse IV steroid and plasma exchange or IVIG or rituximab. If patient is not threatening condition, then the treatment is only heparin with pulse steroid. If patient gets improved with above treatment, then gradually tapers the dose of steroid and started on warfarin with target of 2 to 3. If patient is not improved, then eculizumab or cyclophosphamide is added. Treatment for clinically suspected catastrophic APLA is treatment of triggering factor along with the above. So disseminated intravascular coagulation. Disseminated intravascular coagulation is a hematological emergency reflective of the life-threatening critical illness. It is manifested usually hemorrhagic but can be thrombotic. Causes: acute infection, any kind of infection can lead to DIC, complication of pregnancy like abruptio placenta, amniotic fluid embolism, any tissue trauma, tissue hyperperfusion or acute hemolytic transfusion reaction. Chronic DIC mainly caused by neoplasia, adenocarcinoma, liver disease of retained dead vessel, all these things, and localized aortic aneurysm or cavernous hemangioma. So pathophysiology, if inciting agent and stimulation of extrinsic pathway which lead to consumption of clotting factor and platelet, that leads to bleeding, and if it is a formation of fibrin in the circulation, that leads to thrombosis and ischemic changes. The fibrin and formation of fibrin ultimately break down into fibrinogen and release of D dimer and FDP, and that also can lead to bleeding. So DIC can lead to both bleeding or thrombosis, depends on the situation. Clinical picture: bleeding from at least 3 unrelated sites suggests DIC. Bleeding is more common in acute fulminant DIC. Thrombotic manifestation seen in chronic DIC. Thrombotic manifestation occur during first in malignancy associated in DIC. Other case, hemorrhagic condition and hemorrhagic DIC is much more. Sign of thrombosis is acral cyanosis, skin necrosis of lower limb, purpura fulminans, and localized infection and gangrene. So this is the test we usually done for diagnose DIC, like fibrinogen level, platelet, prothrombin time, APTT, thrombin time, fragmented RBC, whether it is seen or not, to rule out, differentiate between MAHA, FDP and D dimer, and specific factor. Usually all these things are reduced in case of DIC. Now there is a International Society on Thrombosis on Hemostasis DIC score. So this is score for DIC, and it consists of platelet count, prothrombin time, fibrinogen and D dimer. So if the score is more than 5, then it is suspect of DIC. Treatment: the most important principle, the management of DIC, treat the underlying cause. Hypothermia and acidosis should be corrected because they interfere the function of coagulation factor. Supportive treatment and hemostatic therapy have to continue. Heparin is used in restricted condition where thrombosis is clinically problematic or in chronic DIC. Now let's come to in ICU, European guidelines on perioperative venous thromboembolism prophylaxis in ICU. In critically ill patient, this is a recommendation against the routine use of compression of duplex ultrasound screening for DVT. For critically ill patient, we recommended using thromboprophylaxis with low molecular weight heparin or low dose unfractionated heparin, and we recommended LMWH over LDUH. For VT prophylaxis in critically ill patients with several renal insufficiency, we suggest use of LDUH, dalteparin or reduced doses of enoxaparin. Monitoring of anti-10A activity may be considered when LMWH used in these patients. The use of pharmacological prophylaxis in patients with severe liver dysfunction should be carefully balanced against the risk of bleeding. If a treatment is administered, the use of LDUH, low dose unfractionated heparin or LMWH is suggested. We suggest no prophylaxis or use of IPC in patients with a platelet count less than 50,000 and in high risk of bleeding. For critically ill patient, we recommended against routine use of IVC filter for the primary prevention of VTE. We suggest the use of IVC filter in patient who can neither receive pharmacological prophylaxis nor IPC. The selection of non-heparin anticoagulants should be based on the patient characteristic. Argatroban is the first choice in patient with renal insufficiency, and bivalirudin in patient undergo or after cardiac surgery. The use of fondaparinux can be also be considered in this patient, particularly with HIT. That's also.
Here 0 point is less than 30% for its okay, but in Navi less than 10,000. It is increasing in 2 point is more than 20,000. I am not understanding this point. Academy has given 2 points. More than 50%.
What is the absolute fall at the lowest level? We put a combination tower. I mean, what you have to keep in mind is these are, you have to do studies. And to do studies, you need to quantify balance of probability. Ultimately, it is very low probability, intermediate probability, high probability. So, they are not that important in your day-to-day work. But yes, if you are going to do some study on treatment corporate protocol, so ওই দুটো আলাদা করে, মানে একটা 80 থেকে কোথায় গেল, কতটা পার্সেন্ট হলো অর্ধ, আর একটা হচ্ছে যে
Doctor, both of them are less than 10,000. So, other probabilities are more than. So, DIC means use of anticoagulant.
I've never seen anybody do it. I've seen sometimes people use clotting factor, which is massively divergent. But I have never seen anybody anticoagulate patients.
There is mentioned.
It is mentioned, yeah, it is there in the books. They basically those who are thrombotic predominant and those who are bleeding predominant. And then, but I've never seen anybody anywhere. মানে ওই আছে না, যে first do no harm. DVT তো হচ্ছে যে it is very common. এক সময় ছিল যখন স্টুডেন্টস people used to say যে আমাদের দেশে সার্কয়েড হয় না, আমাদের দেশে ক্রোনস হয় না, আমাদের দেশে DVT হয় না. This was a very standard. মানে I remember a very big shot professors দাঁড়িয়ে বলে কি হচ্ছে. It was a big study, which was a postmortem study from PGI Chandigarh. It was a postmortem study that more than 50% of people will have DVT. যেটা খেয়াল রাখতে হবে যে যেরকম আমরা ধরো সার্চ ক্রাইটেরিয়া আছে না, various organ dysfunctional criteria আছে, অক্সিজেন কম আছে, ইউরিক অ্যাসিড বেশি আছে, নিউট্রোফিলিয়া লিউকোসাইটোসিস আছে, কোয়াগুলোপ্যাথি আছে. So coagulopathy উল্টোটাই হচ্ছে, মানে whenever there is a dysfunction in the coagulation system, you can get both bleeding and thrombosis. So lots of patients get some venous thrombosis, some circulatory thrombosis somewhere. Question is, they are all significant. ওখানে আবার ওই severity ব্যাপার চলে আসে. Like we know that just below knee DVTs are probably not significant. Okay. Similarly, high-res CT te, spiral MD CT te, if you see subsegmental blocks, then probably they're not very significant. You not treat them. Problemটা হচ্ছে যে you have to be prepared to monitor these patients. যে আজকে যা below knee আছে 3 দিন বাদে ওটা extend করে যাবে কি যাবে না, এটা একটা problem. কিন্তু you may not treat if you have just a below knee. এটা একটা সবথেকে very
proximal DVT আছে না.
So DVT এর essential ইস্যুটা হচ্ছে যে or DVT হলে ঠিক আছে, post phlebotic leg absent হবে, but it is important because it can lead to a P. Most P's are actually complications of a DVT. So the important thing is prophylaxis, and you have effective prophylaxis available. আর এই হ্যান্ড ওয়াশিং এর মতনই যে তুমি যেখানেই যাও মোটামুটি হ্যান্ড ওয়াশিং রেটস আর about 60-65-70%. Though we know it is a great measure, great tool to reduce hospital-acquired infections, etc. The implementation of DVT prophylaxis is not great. আমরা এখানেও 6-7 hospital মিলে একটা study about 15 years now. It was about 50% use of DVT prophylaxis in patients who were at risk of DVT. The score আছে the use-টা হচ্ছে না. Essentially তুমি যদি দেখো anybody who is in hospital and in bed is a candidate for DVT prophylaxis. The intermittent pneumatic compression devices, we use them in situations where we can't use pharmacological therapy. But whether they change outcome is not clear. they might prevent some diseases, but overall outcome change হচ্ছে কিনা সেটা একটা কারণ এই পেশেন্টদের এই কোয়াগুলোপ্যাথি মানে হাইপার কোয়াগুলোপ্যাথি যদি আমরা বলি এটা তো সারা শরীরে হচ্ছে আমরা তো শুধু কাফ মাসলটাকে চেপে চেপে করছি কিন্তু অন্য জায়গায়ও তো ক্লট ফর্মেশন so we are not effectively treating it. Similarly to that thrombolysis
আমি এটাই ডিভিটি তে থ্রম্বোলাইসিস আমরা করছি না মানে যেটা আমি পড়লাম তাতে বলছি ব্লিডিং এর রিস্ক বেড়ে যাচ্ছে অ্যাডভান্টেজ
সি ওভারঅল thrombolysis massive মানে what they use is limb threatening দেখেছো কি না এরকম হাতির মতো বা নিয়ে মানে একটু venous edema এই অলমোস্ট কম্পার্টমেন্ট সিন্ড্রোমের মতো সিচুয়েশন হয়ে যাবে সো ইন দ্যাট সিচুয়েশন ওরা ওখানেও thrombolysis দেয় বা থ্রম্বোএক্টমি করার চেষ্টা করে বাট আউটকামস খুব বিশেষ ভালো হয় এন্ড ওভারঅল সাবস্টিটিউট অ্যান্টিকোয়াগুলেট করে পেশেন্ট যদি অ্যাকিউট সিচুয়েশনটা বেরিয়ে আসে তাহলে রেসপন্স ভালো হয় আর এতেও যে ম্যাসিভ pulmonary embolism যেগুলো শক হিসেবে বেরোবে such high mortality that you begin to do studies for that sort of patient and ওখানে you can give thrombolysis or you can do embolectomy but thrombolysis এর ওখানেও outcome বিশেষ filters ও আমরা লাগাই কিছু পেশেন্টের but they have not been shown to improve outcome suppose একটা পেশেন্টের একটা DVT হয়ে গেছে একটা PE হয়ে গেছে and a very bad cardiovascular pulmonary status okay clotting একটু deranged আছে একটু ভালো করে so they can use একটা তো একটা pre-filter লাগায় আবার করে নেয় but expensive they have not been shown to improve outcomes D-dimer actually changed a lot of things because I mean DVTP is actually very common in the West এবং ওরা খুব ভাবে এটা নিয়ে প্রত্যেকটা অঙ্কল দিনে দুটো তিনটে পেশেন্ট কোয়েরি ডিভিটি বা কোয়েরি পি নিয়ে আসতো এখন মুশকিল ছিল যে ওদের ভর্তি করতে হবে ভর্তি করে তোমাকে অ্যান্টিকোয়াগুলেট করতে হবে একসময় ছিল অ্যান্টিকোয়াগুলেশন মেন্ট ইন্ট্রাভিনাস হেপারিন দিয়েছে কিনা কখনো জানি না যে to get the dose right for the APTT to be 2.5-3 times is very difficult সে 6 ঘন্টা তখন আমাদের নিজেদেরই ব্লাড টানতে হতো 6 ঘন্টা অন্তর তুমি ব্লাড টেনে পাঠাচ্ছ আর either it goes right up or it goes right down so to achieve the therapeutic balance is not very easy which is why people didn't like it so if you could either exclude যে নেই তাহলে ওইসব করতে হতো কারণ ওদের ওইটা দিতে হতো দিয়ে পেশেন্টকে ইনভেস্টিগেট করতে হতো তখন জাস্ট আল্ট্রাসাউন্ড ডপলার ইজ কামিং অনেক সময় ওই সিন্টিগ্রাফি করতে ওই দেখার জন্য আর পাবলিক এমার্জেন্সি সাসপেক্ট করলে ভিকিউ স্ক্যান করা হতো but if you can go D-dimer in the emergency and the D-dimer is normal we know about this high probability operation, but by and large you are excluding any significant VT. So you can send those patients home. The same with query P where so VQ scan actually that was a very common test done for suspected P's. You have to have matched defects. If somebody is a young fit with normal lungs, you can just do a Q scan. You need to do a ventilation scan. It availability of isotopes. এখানে আমরা ইনিশিয়ালি খোঁজ করতাম ওই সপ্তাহে দুদিন আসতো বম্বে থেকে ট্রম্বে থেকে আসতো ওই দিন যেতে হবে করতে হবে ইট ইজ নট ইজি আর একটা পেশেন্ট তখন যদি কোয়েরি পি নিয়ে ভর্তি থাকে তাকে তুমি কি পাঠাবে যাবে ওইগুলো হবে তারপরে এমবিসিটি স্পাইরাল সিটি এসে জিনিসটা চেঞ্জ হয়ে গেছে উই নাও hardly ever request a VQ scan. For this purpose, it is almost gone out of the window. So that is that.
So, suspected HIT, Nsh-ICU,
suspected.
Induced thrombocytopenia. What test usually do? Because he was telling that TF4 assay or serotonin assay. What do you
Either.
কিছুই তো করি না।
মানে ওগুলো বললাম যে see basically the thing about it is that it's not that common, but it is you have to keep it in the back of your mind. The problem
আমরা যেটা করি ফর্ম মানে হেপারিনটা বন্ধ করে দিয়ে
সেইটা একবার কথা আছে যে ফার্স্ট যে the problem is not from thrombocytopenia, the problem is from clotting, problem is from thrombosis, so that is the problem. তারপরে ধরো একটা ডিভিডি পেশেন্ট নিয়ে এসছে, তো তুমি ভাবছো যে পেশেন্টের তো একটা থ্রম্বোফিলিক টেন্ডেন্সি আছে, তুমি তাকে অ্যাপ্রিন দিলে, তারপরে পেশেন্টের আদার থ্রম্বোটিক ফিচার্স ডেভেলপ করছে, so it is quite easy to go down the route যে এটা কোনো সিভিয়ার থ্রম্বোফিলিক ডিসঅর্ডার আছে এটসেট্রা, কিন্তু তখন এটাকেও ভাবতে হবে, আর ওই 7 দিনের মাথায় প্লেটলেট কাউন্ট কি কমছে দেখা, এটা দ্যাট ইজ ভেরি ইম্পর্টেন্ট। আরেকটা এখন জানি না আছে কিনা একসময়
one thing is as a treatment portion the direct thrombin inhibitor that is Gangopadhyay, all those things we need to start. And then if we are not doing those tests in CFPF,
no, you will thrombotic cabinet of the antibiotic
we start.
So you see, so what is the patient DVT নিয়ে আসে, the standard so তুমি heparin আছে, আমাদের লোকাল লেভেল heparin দেয়, ওই আগে heparin ভাবে generally use করে না, and simultaneously you start and মানে say in my case I would start warfarin, ঠিক আছে?
I am telling about heat, it's HIT.
হ্যাঁ আমি বলছি, so তুমি তো heparinটা দিয়েছো কাকে?
As a thromboprophylactic,
as a thromboprophylactic দিয়েছো, and then you will have to then
just 4 to 5 days or 8 to 10 days on heparin. And now I am suspecting heat in sudden follow-up tests like that.
So you swap.
So you have stopped heparin.
You stop heparin, but
you have to start this direct acting.
You can do direct, or what we were doing is and warfarin দিয়ে okay. But fondaparinux is also low probability, but not a no probability. মানে এই নতুন গুলোর সম্বন্ধে I was welcome Anush is here. I have some reservations about the newer anticoagulants. I would say increasing use হচ্ছে। একটা তো এই
লিভার অক্সিজেনকে নিয়ে স্টাডি যেগুলো হয়েছে বেশিরভাগই মানে লিভার অক্সিজেনের উপরই।
না আমি জেনারেল ইউজে কথা বলছি, যে একটা জায়গায় তুমি বলেছিলে যে valvular warfarin is still preferable in valvular heart disease and also in
prosthetic
and also in APLA it is preferable. এখন যেটা হচ্ছে যে newer anticoagulants এর কথা বললে, যে newer anticoagulants somehow there are even few years ago it used to be a tough time convincing orthopedic surgeons and surgeons to give DVT prophylaxis and use anticoagulation etc. কিন্তু এই যে মনিটরিং লাগবে না এই ব্যাপারটা কিনে somehow they have become the pioneers of using, and so a lot of orthopedic patients are going home on cardiac patients আছে, neurological interpretation patients আছে, oncology patients আছে এখন, so there is a big number of patients in the community who are on these newer anticoagulants. এখন তাদের bleeding manifestations হবে because it's an anticoagulant, তাদের surgical procedures লাগবে, anesthetic procedures লাগবে, তো ওটা you have to be clear in your mind as to how you will deal with those patients. তাহলে anesthesia তো guidelines আছে, তো গাইডলাইন্স তো আছে যে তুমি কতক্ষণ আগে বন্ধ করে দেবে, তারপরে এপিডুরাল লাগাতে পারবে কি এটসেট্রা, বাট ইফ সামবডি কামস উইথ ব্লিডিং ম্যানিফেস্টেশন দেন হোয়াট ইউ ডু, এগুলো ইউ হ্যাভ টু বি, আর এই যে মনিটর করতে লাগবে না এই কথাটা, ইফ ইউ অ্যাকচুয়ালি গো ইনটু দ্য ডিটেইলস, যে মনিটরিং করলে তো ভালোই হয়, কিন্তু মনিটরিং করার যে টেস্টগুলো দরকার সেগুলো নট রেডিলি অ্যাভেলেবল and are very expensive.
Factor 10 assay
directly তোমাকে 2A assay করতে হবে, activated assay করতে হবে, they are not available. তবে because the sort of dose response is more predictable in those patients, so you are getting away without doing it. যেমন বফরেনাল কিছু লোকের আয়নার 2.5 নিয়ে যেতে 5 মিলিগ্রাম লাগে, কারণ 10 লাগে, কিন্তু in case of these newer ones the dose response is a little bit more predictable. That's where you're getting away. If the problem is somebody starts bleeding, তখন তুমি which is why I mean, most of the patients I need to anticoagulate, I somehow ultimately I fall back on warfarin. If there is a problem, at least I know exactly.
We learn the reversibility of the drug that we are going to use. Anti-tendon inhibitors problem আপনি বললেন যে it starts bleeding then what? যেটা আমাদের warfarin বা heparin এর সুবিধা. Remove the moment we stop a certain amount of time, and if required, we can reverse as well.
So drugs have come. Companies, drugs, NSA, they are extremely expensive. এই যে তোমার Debottam, যেটা Predux, যেটা original যেটা, ওটার যে Praxpine বলে পাওয়া যায়, Adalimumab, and that is মানে reversal doses মানে in US dollar terms is about $50,000. সেটা ওখানে কিছু জায়গাতে the company provides free if required. আমাদের এখানে ওই পেশেন্ট বলে টলে যায়, বাট তোমার মাঝে যাতে একটা সময় পেশেন্ট ভর্তি হলে বাড়ির লোককেই পাওয়া যায় না, তো বাইরের লোক, তাই না? So that is a problem. It is the same with this Epixaban, which has now become one of the most commonly used NOACs or DOACs. I think these drugs are no longer new, but these reversible agents are actually new. ওখানেও একটা drug এসছে, anti-10A some activity, andexanionic কিছু এসছে, it's anti-activated 10A antibody around it.
So our concern that the preoperative patient will be wide. There is any probability that this patient might go some surgical procedure. Please,
so I'm sure
refer heparin or answer or NWH max. Do not use orally active,
আগে বন্ধ করে দিতে হবে, তার কিন্তু ব্রিজিং ব্যাপারটা দিতে হবে।
এই সময় হেপারিন গুলো মানে আইনলিস্ট করে দিতে পারবো। হ্যাঁ, সিচুয়েশন কিন্তু যদি orally অ্যান্টিটেনে পেয়ে যায় তাহলে ইট ওয়াজ ভেরি ব্যাড। সেটা probability patient থাকলে make sure the patient gets either unvaccinated or NWH. Don't give Epixaban, Rivaroxaban,
which is why দেখবে যে এই এরিয়াটা নিয়ে অ্যানেস্থেটিক সোসাইটিজ আর মোস্ট অ্যাক্টিভ। কারণ
সেকেন্ড পয়েন্ট হচ্ছে যে আমরা যখন টার্মটা ইউজ করি ভিটি, ভেনাস থ্রম্বোএম্বোলিজম, ইট ইনক্লুডস বোথ ডিভিটি অ্যাজ ওয়েল অ্যাজ
যেটা বললাম যে নিউম্যাটিক ডিভাইসগুলো তো শুধু কাফটাকে চাপড়াচ্ছে, বাট ইট ইজ আ সিস্টেমিক ডিসঅর্ডার, ইট ইজ নট জাস্ট আ লোয়ার।
একটা হচ্ছে আমাদের ওটিতে খুব কমন ইউজ হয় একটা স্টকিং অ্যাক্টিভিটিস,
stocking
use করার প্রয়োজন আছে আপনাদের
to be honest, stockings are more of a comfort device, or you post phlebitic leg and then what allowed.
Sir, one thing sir regarding TTP is if you are suspecting, do we do the Adamkias 13 as
I have done that. I like তিন technique, একটা হচ্ছে differential diagnosis, TTP, SLE and sepsis. মানে এগুলো সবই
want to differentiate between HUS or TTP,
মানে how তোমার হিস্ট্রিটা যদি ওরকম থাকে, আর HUS এ জেনারেলি নিউরোলজিক্যাল ফিচার্স থাকে, নিউরোলজিক্যাল ফিচার্স থাকলে দেন ইউ লিগালি
treatment portion there is less than 10% activity of
ওরকম ভাবে কেউ করে না, মানে the patient is unwell, আমার কাছে নিউরোলজিক্যাল ফিচার্স and then নিয়ে এসছে মাইক্রোবায়োলজি কিংবা নিয়েছে থ্রম্বোসাইটোপেনিয়া নিয়েছে, you will treat them. And so ওখানে এই অ্যাকিড সিনড্রোম in a patient of sepsis হতে পারে, তো ওখানে অ্যান্টিবায়োটিক তোমাকে দিতে হবে and support তোমায় ওই স্টেরয়েড লাইক প্লাজোফেরেসিস করতে হবে। SLE হলে the steroids become more important, and if you don't know তাহলে this is all supported shot but I have not encountered people wanting to do these tests or wait for results to, if somebody's got a special interest and somebody's doing some research,
some approach chart means we have started treatment, we check the trend of platelet rise along with the Adamkias 13 activity. If this platelet is rising but the TS activity is still less than 10, then we should continue the treatment like this. There is a
সেটা আছে, but in the sense if your platelet is rising and the patient is getting better, and if your further coagulopathy is settling, then that is your measure.
More or less we check it clinically.
That is I have যেটা বললাম যে maybe if you are working in a specialist center যেখানে ওরা এসব করছে, but this is not
Readily available.
Yes, it's not readily available. It is be available in research setting that you can specialized centers.
Sir, what the specialized center means? In Kolkata means the apex.
No, I'm not talking about Kolkata.
In Kolkata is it done?
I have not come across. Okay? I have not heard anybody talk about it. And we get patients which we think TB might fix with all this criteria and we treat them and that is HOS তো বেশ কিছুই হয় nephrologistরা আরো দেখে because they generally get তোমার একটা স্লাইডে ছিল যে ওই HOS এ কি coagulation নরমাল থাকে ওটা তো ঠিক না আরো যা পেছো normal LFT coagulation profile তো normal হবে না মানে তোমার thrombocytopenia আছে তোমার ওই consumption হচ্ছে thrombocytopenia তাহলে এটা গন্ডগোল হয়ে যাবে generally they all have a very DIC like picture তোমার platelet কম থাকবে তোমার time APTT দুটোই বেশি থাকবে fibrinogen high থাকবে D-dimer low থাকবে D-dimer high থাকবে আর microangiopathic ওই schistocytes গুলো fragmented RBCs এগুলো ওরা দেখে ওরা মাইলাতে ফোন করে
Another thing, sir, in treatment of DIC, there is one point that we can add fibrinolytic. If there is a trend of fibrinolysis.
And
Dual 2 means the thromboelastography routine if you are suspecting DIC.
Dual?
Thromboelastography. How do you suspect that the patient?
I have only seen thromboelastogram being done in the liver transplant units. So I have worked in a hospital where they did liver transplant. They used TEG in liver transplant patient, but it was not available to us.
Whether to use
antifibrinolytic দিতেই পারবো অসুবিধা কি আছে antifibrinolytic agents দিতেই
so there is phases of DIC means hypercoagulable state fibrinolytic
মানে
if we give it in a coagulable state then it becomes
no but they give even with এই পেশেন্টদের ওরা দিতে পারে নোম্যাক্সের যে পেশেন্টগুলো ব্লিড করছে হ্যাঁ তার ওখানেও But we have not quite reached fine tuning a jaga to guide our management in these situations. And in real situations, there are sick patients.
Still, this is largely clinical.
I mean, the hematologists can do a lot. Lots of tests. Again, if you see, even I remember they were doing a meeting in this pulmonary renal syndrome. The nice case lady comes with this and that etiology, cardiology, hypoxia, renal failure. So, if you come to a panel, so everybody starts saying, vasculitis, microscopic আগে তো আমরা ভাবি sepsis টা আছে এটা তুই যদি microscopic vasculitis ভেবে না তাহলে তো you're going to hit with steroids কিন্তু you have to worry about infection first and that can cause all of that it is the same with all these combinations apply মানে আগে apply diagnosis করতে লোকে অনেক লাফালাফি করতে পারে you see the criteria is very simple মানে clear very clear very simple I've got a few applications মুশকিলটা হয় কি ওই আমরা এখানে anticoagulation monitoring মানে the quality of P-time monitoring in local labs is so poor we've all had patients having major complications including death so look at the fire there was a lady admitted under the surgeon young lady structures with pain abdomen, severe pain abdomen and investigated a splenic infarct. Patient came to me, they can have splenic infarct, so I was trying to work her up into then she got admitted in SSKM with chest pain was thought to have had a month. They even did a coronary angio, which was reported as normal, however I had to ask them the children. But why would a young patient have? And then I looked through her file and all her platelet counts were on the lower side. So it sort of drops. Then his son was a guy who was as interested in all this and we did all the tests and it was she was going to require anticoagulation. So when you talk to the family, the husband probably drives an auto or something, মানে জিনিসটা বুঝবে না, offer is not expensive, জিনিসটা বুঝবে না, সমস্যা যদি হয় তখন কি হবে, so ultimately they did not take anticoagulation. Then she went off to bed, মানে যা হয় যে যখন বুঝতে পারছি না কি হচ্ছে একটা সমস্যা হচ্ছে, and they also confirmed the diagnosis of APLA. They also did not anticoagulate, which I think then the patient came in acutely in the middle of the night with his left hemiparesia. Stroke damage, massive. Upon our Konatata Bole, she's on warfarin and she has had reasonable recovery. Back to normal function, so I have Konatata hospital where I have to use it. But now they religiously take the warfarin and hypercalation to them. That's what it is. I've got a few secondary APLAs also who have ANF positive through the obstetricians. But ওই simple test এই diagnosis হয়ে যাচ্ছে, তোমার glycoprotein আছে আর ওই IgM, IgG, cardiac lipen আছে, আর PDR এর উপর দিতে পারো উপসারিক augmentation এর উপর. It's very interesting. Bleeding के क्या একটা meeting আছে? Bleeding is না.
Tennis করে, ITP tennis করে আছে. ITP ফিটা অনেক বেশি বলেছে।
আর সে ব্লিডিং এর একটা
খালি ফিটা কোশ্চেন আছে তো।
হ্যাঁ, ফিটা
ফিটা আলাদা সেপারেট আছে।
যে না যেরকম you have sick patients who then suddenly যেখানে পড়াচ্ছে ব্লিড করছে এসে প্লেটলেট কাউন্ট করে, so bleeding in a particularly ill patient এটা একটা ওটা approach কি করবে ওটা মাথার মধ্যে একটা রাখতে হবে। Simple with that. Good, thank you. Next.